All right. So before we get started, how many of you have had the experience of having a loved one, or maybe even yourself, a family member, a child, a friend who's been in the hospital? All of us, right? So don't we all want to be prepared when we have that loved one in the hospital, especially if it's one of our parents, an aunt, uncle, grandparent, to be more prepared on what we should be asking, what we need when we leave the hospital. So hopefully tonight we'll be able to answer some of those questions and help you navigate hospital discharge and what comes after.
And I do want to just put a disclaimer out there. There are several healthcare systems here in Metro Atlanta, and each one is going to be a little bit different. So just keep that in mind. What we speak about today is a lot of our process at Northside Hospital. It should be the same, for the most part, despite what healthcare system you go to. But there will be some tiny nuances. And here we are. And just my name is Mark, so I'm the manager for care coordination for the Northside system. I primarily deal with, our process, internal process, as well as oversee all of our complex patients within the system. So those that are extremely difficult to get discharged from the hospital.
And I'm Mary Wilkie. I'm the manager of care coordination for the Cherokee campus.
All right, so hopefully tonight, you guys will be able to understand why we do what we do and who dictates that for the hospital. Learn how to request and work with either a case manager, care manager, discharge planner. Be confident in advocating for your loved one and also for yourself. And then also, prepare for discharge home, whatever that plan will look like. So why do we do what we do? Who's heard of Medicare? Who's heard of CMS? They're a pretty big company. They're a pretty big body, a governing body. And so they outline the bare minimum of what hospitals have to do. And they give us directive. If we want to receive their funding, then we have to comply to those rules. Also, there's going to be a lot of things on the slides. I will email them out if you want them. So don't feel like you have to write everything down. Just want it to be there in case you guys do want it emailed. So they tell us what to do. And some of those things are related to the discharge planning process. So if you are going home with a new service, home health care, to a rehab, to anywhere but just home, the patient has the right to choose. The hospital can't just say, hey, we want you to go home with this provider and only this one, and that's the only one we're going to set up. That is very frowned upon. And so we will always have to ask, who would you like to choose? Now, that might not be an option based off of the facility or the agency, but we will always do what we have to do and what we can do to advocate on behalf of your loved one in the hospital. And then the right to be involved in your care, especially as a caregiver. CMS requires us to work with the care partner, to work with their loved ones, because at the end of the day, the more support a patient has, the less likely they're going to come back. And I don't know about y'all, and we'll talk about it in a little bit at the end, but a lot of people don't want to live at the hospital. It's not a great place. There's a lot of germs around there. And so, we really try our best to get it right the first time, and we want you to stay home. And then there's a whole bunch of other things, but the biggest one is just caregiver involved. And so what is it and why does it matter? So we are going to be working with you, with your loved one, with anybody that's involved in someone's care, and trying to figure out what's going on. Where did we come from? How are we doing at home? What issues were we having? And what is the plan? And this often starts pretty early. And you get to the hospital, you're going to be in fight or flight mode. Your loved one isn't going to feel like wanting to talk. But we, again, due to CMS, we have to start this process early, because within an agency, we have to show them that we are doing our due diligence and being fiscally responsible for any of the funds that come into an organization. And so that is something that we are directed to do in order to maintain CMS as a funding source. any hospital. And so, we might see you in the ER. We might see you when your loved one's in surgery and talk, give the relative a call and say, hey, paint this picture. What's going on? What didn't work well? What services did you have? And unfortunately, and Mary, I think, can attest to this, more times than not, they will say, well, they're current with a home health care company, but I don't know which one. Or, oh, I think I'm on hospice, but I don't know who. Or if I'm even on it. And so there's a lot of information that can be very hard to get. And that's when we do rely on our caregivers to really kind of help support us. We're going to evaluate for that next level of care. It might be home, it might be a rehab, it might be to another hospital. So we'll work with the family and the patient to get that figured out. And then also, I can't stress the role that caregivers play in this process. Truly, are so many studies that show those that have an involved care partner have such better outcomes. And unfortunately, not everybody has that care partner in their life, and we see it. And so, really trying to build your own confidence and even the confidence of your loved one to advocate for themselves makes a dramatic difference. And so there's many rights that a patient has and that a caregiver has, but the biggest ones that I want to kind of highlight on here, obviously, is the patient's right to choose a facility. We're not just going to dictate where you go. Now, you might give us an option, like I said, and if they say no, we're going to go to the next option that you choose. But there are limits to some of the options that exist. And then as a caregiver, you have the right to be involved with your loved one. But there's a caveat. If they don't want you involved, then you're not involved. Even if you're a POA, a power of attorney, if they are having capacity, and if they're like, I don't want my daughter to know she is crazy, and she just wants to put me in a home, and we deem that she has capacity, we're not talking to the daughter. Now we will try to work with her and be like, hey, let's put a family meeting together. Let's bring us all in the room, because I think she has your best interest. And at the end of the day, she might say no. Okay, we're gonna keep trying though, because at the end of the day, we know the value of the support that a family member brings. And normally there's a happy medium. It might not be going to the home. It might be, hey, what other services can we do? What other support can we put in place to make you successful? But that's probably one of the biggest areas that we see when it comes to, the rights of a patient and caregiver is, the contention that a child might have or want for their parent, and they're not on the same page. And so we work pretty regularly, in bringing in some extra support to have some of those tough conversations. And to really look at, what's the driving factor, what's the driving problem, and how can we meet in the middle? And so, those are probably the biggest things that I want to really touch on this slide. All right, so again, each hospital is a little bit different when it comes to defining who's going to be doing the discharge planning. So you might hear it's a social worker. You might hear it's a case manager. You might hear it's a care manager. You might hear it's a discharge planner. They're all synonymous. We just like to confuse you. Like anything in healthcare, it's not easy. We throw out 3-letter acronyms all the time. And so if you say one of those things, though, typically discharge planner, they'll know who you want. And it can be a nurse, it can be a social worker. Mary and I are both social workers, but at Northside, we also have nurses. And, they are doing the same job. So they're going to get you to where you need to go. But that's not the same at each healthcare system.
As a nurse versus a social worker, is one better for certain particular patients? I mean, you're saying that both can do this, but.
So it depends on the model. So within the case management field, there's different models. So at Northside, we have nurses and social workers, and they do the exact same role. So, we train them to be able to handle all of these situations. And each of them will have different kind of background experiences. But, typically at the end of the day, like we all kind of converse, we work together. If there's a situation I've not seen, I might go to a nurse and say, hey, what's this? But at Northside, ours would be the exact same thing. And normally they don't differentiate, like I'm a nurse, but that's not the same for the other systems. And so asking for us, say that's who we want to see, we want to work on getting mom discharged. And, that person will hopefully come with you. Again, per CMS, there's different policies that the hospital has to follow. And it's going to be kind of healthcare system specific. Like we have our own policies on when we will see a patient and what time frame we will see a patient. And so, normally we'll see you before you even request to see us. And we're gonna actually, ask all of those questions, and we're gonna find out all the information, get real up in the business, because we want to make sure that we know the complete picture. And we're gonna help navigate insurance. We're gonna help make sure that your hospital gets paid, that the bill gets paid, that it gets approved, that where you're going is gonna be in network and be approved. So, we're gonna do all of that. And if for some reason you have not seen a social worker, nurse, care coordinator, case manager, enter all the other things I just said, then you can always ask. Every hospital is required to have somebody who can assist with discharge planning. So again, discharge planner, I promise you somebody will come. And so how do you work with them? And I think this is one where it's even uncomfortable for us because each case is very different. And it might seem like we are trying to get up in your business, and we are. We want to know what's the income, because I want to know that you can afford all of the things at home, because you'd be surprised. And there's a big push of social determinants of health. If you're living paycheck to paycheck and you're not able to afford your health care, you're not able to afford your medications, and you're just worried about keeping your lights on and a roof over your head, we can help with that. There's so many resources that we can hook you up with, or hook your loved one up with, to make them successful, to be able to stay at home longer. So, I mean, it can seem very intrusive, and it can, really seem like, why are you bothering me? Why are you asking? And there's a reason. And I encourage you, if something doesn't make sense, ask, and inquire, like, hey, how is this important? Like, I'll tell you, I just want to know, because all of your healthcare information is going to be protected. I mean, it does fall under HIPAA. We can't share this with your neighbor down the street. We can't share this if, another person calls like, hey, can you tell me all of these things about, my aunt? Well, you're not a care partner, no. And so, we try to get the biggest, most complete picture that we can, just to make sure that your loved one is set up for success. And oftentimes we do rely on a caregiver for that information, because mom doesn't know. It never ceases to amaze me. Some of the things that I take for granted that I'm able to recall. And, some of even the most basic things, like, do you have a bank account? How do you pay your bills? Like, I don't know. My daughter does it all for me. And so, we rely heavily on the family members when it comes to that. And so, let's see. Going over, oh yeah, when is discharge expected? So, throughout the process, depending on how long one is in the hospital, we'll follow up, we will touch base. A plan can always change. It might be that you're going, the plan is to go home, and there might be an infection that happens, and your loved one needs to go to a skilled nursing facility, or they might need home health care. We always evaluate the possibility based off of recommendations from physicians, physical therapy. If that plan changes, and we talk to you. We talk to your patient, your loved one. And, we make sure that everything is okay. And, again, even after all that we say, and, mom doesn't want to go to a skilled nursing facility, and you don't want mom to go to a skilled nursing facility, you have that right. Do we always agree with it? No. But we make sure that it happens. And then we'll make sure that you are, again, they're set up for success. And this is my favorite. Limits do exist. Okay. Insurance can only do so much. There's often times where there are instances where we are called to perform miracles. And I don't know about you all. I am not the man upstairs. I can only do so much. And I got a realtor. I can't buy somebody a house. I can't get them a new house. I can't make sure that I pick them up in my own car to take them to an appointment. So there are a lot of limits within what we can do. And oftentimes it can come off that, we don't care. And I hope if you ever, experience one of these limits, that the person that's having that conversation is able to explain, the why and the rationale. But there is a lot that in healthcare is getting so much more complex every single day. And, and I get bombarded with a new situation almost daily of what to do. And, it's only going to get more complex. Things are being taken away. And so it's one of these instances where we will try our absolute best to make the plan happen that your loved one or that you want to have happen, but it might not occur. That doesn't mean that we won't try.
Okay, so once the social worker, nurse, case manager, discharge planner, care coordinator, whatever title you want to give them, once they have come to you or your family member, talked about what happens next? Well, physical therapy is saying, your mom is not safe at home. She lives alone. She's going to have to go to a skilled nursing facility. So those conversations will happen with the care coordinator. And they should explain, what does that look like? What is that? Who covers that? What do they do there? How long is she there for? What are the steps to get her there? There's a lot of components in that. So oftentimes we are the ones who have that first conversation. Mom lived at home independently and she broke her hip and she lives alone. And the daughter lives in Michigan. So daughter flies in and she's like, I want to help mom get situated, but I can't stay here. I can't live here. What's going to happen to mom? So we explain what the next levels of care are. And one of them is a skilled nursing facility. So when a patient meets criteria to go to a skilled nursing facility, they often have a skilled service they need. So mom broke her hip, or mom has a blood infection and she needs IV antibiotics, or mom has severe wound care needs. Those are all skilled services that are covered under Medicare for mom to go to a skilled nursing facility. Oftentimes, it becomes harder and harder with insurance companies to get mom approved to go to a skilled nursing facility. A lot of our population is switching over to managed Medicare plans. And they dictate whether mom can go to a skilled nursing facility or not. They will often, because we'll submit the information, the therapy notes, the physician notes, what IV antibiotics they're on, whatever it might be. And that insurance plan dictates whether mom is approved to go or not approved to go. And we have seen on many occasions that we feel like the patient is very appropriate for that level of care, but the insurance says, no, we're not paying for that. What's next? What do we do? Well, in those circumstances, we'll have a backup plan. So if mom needs to go to a skilled nursing facility and that's denied, we will have to have tough conversations with the patient and the family about, can you pay for a caregiver to come in home? Do you have church friends? Do you have other relatives that may be able to assist you? We are going to help you to appeal that denial with your insurance company. But in the meanwhile, you're medically stable for discharge. What's next? So the care coordinator who is dealing with all of the discharge plans will be having conversations very, very upfront, setting expectations of what's next. So the levels of care, discharge options, when we talk about rehab, there's skilled nursing facility, which is a nursing home rehab, and then there's acute rehab. which is inpatient, like Encompass Acute Rehab or Shepherd. So we have a lot of patients that come in and their family member, mama came in with a UTI. And the daughter's like, mom's not going anywhere else but Shepherd. And oftentimes that's an unrealistic discharge plan. We know that you want the best for your mom, and those conversations happen up front. If that's my patient and I talk to the daughter, I say, absolutely. I'm happy to make that referral to Shepherd, but in my experience, they usually have patients who have higher needs for rehab. We're going to go ahead and make that referral. But for our backup plan, we're going to look at skilled nursing facilities. We're going to make sure that when your mom is discharge ready, she's medically stable, that she has somewhere to go. But I don't want to be the person that says, no, Shepherd's not going to admit your mom. She's denied. I'm going to allow Shepherd to make that decision. And I'm going to help and advocate for that patient, that family, and what they want. But at the end of the day, I'm still very realistic about what the options are. So discharge options as far as facilities, SNF, which is nursing home rehab, and acute rehab. And so if a patient discharges to a skilled nursing facility and they have straight Medicare, Medicare will cover for a patient to go to a skilled nursing facility at 100% for the first 20 days. But they have to have a qualifying hospital stay of 3 midnights as inpatient status. So these are questions that your care coordinator will be able to answer. They should be able to tell you up front, hey, I know you want your mom to go to a skilled nursing facility, but your mom's only here for observation. She came in, with dizziness, and she's not going to qualify to go because she doesn't qualify for an inpatient admission. Or if somebody's in the emergency room and they say, hey, I'm bringing mama here, we need placement, and they have Medicare. Well, unfortunately, from the emergency room, that patient is not inpatient status, and that Medicare is not going to cover them to go to a skilled nursing facility. And that's why we rely on our community partners, because what ends up happening from the emergency room is we're setting up home health care, we're setting up private care, we're setting up hospice, we're setting up transportation. We're throwing as many resources as we can to ensure that that patient is safe. Now, and we speak to the family about, hey, Medicare's not going to cover that. I'm happy to make a referral if you want to pay privately for it. But if we're going to, if they're going, and my advice to them is if you're going to use that money to pay privately to go to a skilled nursing facility, that money would be better used to pay somebody to come into your home and stay with them. It'll go farther. But we have lots of conversations with families about skilled nursing, what that looks like, what it entails, and how to get there. So they have standard Medicare. It requires a 3 midnight stay, and they have to have a skilled service. So even if it's managed Medicare, they have to need physical therapy, nursing for IV antibiotics, wound care, speech therapy, somebody just had a stroke. So those are all criteria to go to skilled nursing. So the care coordinator is going to have a conversation with you and your family member and say, hey, we're going to make a blanket referral to a 25-mile radius. And let's say somebody lives in Macon and the family desires placement in Macon. So we'll do a referral in a 25-mile area in Macon because that's their preference. So once we make that referral, we'll come back to the family and say, hey, and the great thing about technology now, everything's electronic. So we send those referrals electronically, and then we hear back usually the same day electronically. Hey, we have a bed, we clinically accepted them, and if they choose us, we need to start insurance authorization. So we'll go back with a list to the family member, the patient, and say, we made referrals within a 25-mile radius from Macon, Georgia. And here are 50 facilities. 25 of them have accepted your mom. which of those 25 do you want us to start authorization at? And so we do not push for a patient to go to a specific facility. We offer the patient and family choice of whatever they want to do. And we recommend that they tour facilities, that they look at CMS's website, that they have knowledge about each individual facility or wherever they want to send mom to. Because when you go to Northside Cherokee, it's a beautiful hospital. But once you leave Northside Cherokee, most of our skilled nursing facilities locally are older buildings that it is night and day. And I try to paint a very realistic picture in saying, hey, your mom's going there for rehab. It's going to be really important for you to tour this facility and make sure that it meets your standard. Because, and it is night and day. All right, so they have the right to choose their facility. If the insurance denies, I've already talked about that. They do get therapy, typically 5 days a week at a skilled nursing facility. They get nursing care, they get medication management, and help with their ADLs. And we spoke about that, choosing facilities. All right, so a lot of people, when you've never experienced hospital stays, post-acute discharge stays, you don't know what to expect. And so we try to paint a very clear, realistic picture so that your expectation meets reality. A skilled nursing facility is in a hospital. The staffing at a skilled nursing facility is not the same as a hospital level because we're acute care. The skilled nursing facility is subacute care. So the staffing ratio is different. They don't have multiple doctors there that round on patients every day. They have one medical director. A place with no independence, that's not accurate, that's skilled nursing facilities attempt to help patients regain their function when they're there for rehab. It's not just for the elderly. We actually have a whole lot of we are seeing more and more younger populations that need skilled care after a medical event. We recently had a 45-year-old male who had a massive stroke. And he ended up having to go to acute rehab, which is a higher level of care. And that type of medical need is appropriate for acute rehab, like Shepherd. And a skilled nursing facility is not assisted living, and it's not a sad, lonely place either. I frequently do visits to our local skilled nursing facilities quarterly. So we make sure that we are good partners for skilled nursing facilities, that we have conversations about, are you getting everything you need to properly care for our patient when they leave the hospital? We want to make sure that you have all of the documents you need, all of the orders, all of the prescriptions, all the things that you need to ensure that our patient who leaves our hospital is set up for success. All right, so then the other option is a patient isn't going to go to a facility when they leave the hospital and they're going to go home. Well, there's a lot of things to consider. If mama lived at home by herself, alone, with no support, then some of the things that we need to make sure when mama goes home is that if she's going to go home alone, is some of the things that she might need. If she's been in the hospital for 3 weeks, she's probably going to be really debilitated. She likely won't be able to be there by herself. Will she need somebody to help her with her medications, with her meals? Will she need somebody, will she need the hospital to set up home health care for her, which is a nurse that comes out and therapy that comes out to the home. Now, one of the things that a lot of patients and families don't understand about home health is they think that once we get home health, we're set, because there's going to be somebody that stays with her if we get home health. Well, unfortunately, Medicare doesn't pay for a caregiver to come out to your home. So it's kind of the same when we talked about skilled nursing. Medicare pays for a skilled service. So the nurse is coming out to do a skilled service, which may be IV antibiotics, it may be wound care, it may be medication management, but there's a purpose in their visit of a skilled service. Physical therapy is coming out for a skilled service, speech therapy, occupational therapy. They don't send somebody out to sit with mama and bathe mama or change mama or make her meals. And I think that there is this idea that that's what home health is. Well, unfortunately, the home health that's covered by Medicare and insurance is not that. So if that's what mama needs, then we assist in setting up services like with Christian. If mama needs somebody to sit with her, we can absolutely link you up to the service that you need for your mom. But home health that's covered by Medicare is not that service. All right, so now you're at the end of your hospital stay, and now you're like, okay, mom's gonna go home. We're getting all the things set up. What are the things that we need to make sure as a caregiver that we have when mom goes home? And so we want to make sure, especially if mom is demented, or mom has been in the hospital for 2 weeks, she's likely not very clear. She's not going to remember all the things in her discharge paperwork. She doesn't know that her medications changed. These 3 medications changed, and this one was added, this one was taken away. All of those things, unfortunately, become the burden of the caregiver. And that's why it's so important for our patients to have caregivers, because it's so hard to remember all the things. So understanding medications, arranging follow-up. Follow-up is super important, especially when we have patients who come into the hospital. We do acute care. We fix the problem, but there may be some ongoing issues that need addressed. Well, without support from a caregiver to assist with setting up those appointments, transporting to those appointments, then there's medication changes from those appointments. Those are all so important to document and to change, because if we want mama to be successful, then those are items that we need to make sure that we stay on top of. Caregivers, equipment. So when mama leaves the hospital, if she needs a walker, a wheelchair, a hospital bed, those are all things that need to be discussed before she leaves the hospital. And typically we have a fantastic therapy team at our hospital. So they come to us and they say, hey, we saw Miss Smith, she's gonna need a walker. Or hey, we saw Mr. Smith, he's not getting out of bed, his mobility, you might need to speak to them about getting a hospital bed. So the communication within our team helps us to manage whatever is needed for your mom or loved one when they discharge from the hospital. But if it's something that we didn't see and we don't know, then that's where you as a caregiver need to say, hey, can I talk to the discharge planner? I know that you guys recommended that mom go to a skilled nursing facility, but we're gonna take mom home and I'm gonna need a hospital bed. That is completely appropriate to ask for a discharge planner when you know that there's something that your loved one needs and we haven't talked about it. All right. Right, so after they get home, we try really hard to get it right the first time. When your loved one goes home, we want to make sure that the services that we put in place are the right services. That we don't want to delay whatever your loved one needs for another admission. We try really hard to prevent your loved one from having to come back to the hospital. But sometimes it happens, and things that as a caregiver, when your loved one goes home, we should all watch out for are their pain or increased in symptoms of why they were in the hospital. confusion, medication problems, falls, increased weakness, and just know when to call 911. And if we have established home health care for you and for your loved one, then they often say, call us first. If there's something going on, call us and we will walk you through if it's something that we think that we can't manage at home. All right, so this is not what we want to happen. We don't want patients to leave the hospital and then just take, the escalator right back in. So we're gonna do everything that we can to make sure that things are set up the first time. All right, so readmission prevention. So when your loved one's in the hospital, it's so important that if you have questions, ask. If you don't know what's going on, you don't know how to do something, you don't know what the next step is, ask. It is, we want you to. We want to make sure that when somebody leaves the hospital, that all of their questions are answered. Understanding their illness, asking questions, understanding medications, ask questions, and their follow-up, ask questions.
There's a common theme with asking questions. We know, I mean, healthcare is incredibly complex. Medicine, incredibly complex. It takes doctors how many years to go to school in a specialty, and half of them still have to Google things. So, it is unrealistic to expect, a patient who is in the hospital, sick, tired, wanting to go home to fully understand, what's going on with their condition, why they were in the hospital, and what they need to do in order to be successful outside of the hospital. It's going to also be hard for a caregiver. Again, the caregiver will have a little bit more capacity to, help remind, your loved one, hey, don't be taking those stairs so quickly, or hey, this medication was changed from this dose to this dose. Did you take one or two? Oh, you took two? Okay, that's not good. It is very hard for patients, especially, again, going back to when you or your loved one were in the hospital. How long was that discharge paperwork? How many pages? It's a lengthy document, and it's almost like you are, buying a house with some of the papers that you sign, when you're discharged, and that you acknowledge it. So, before you sign, truly try to understand and advocate and ask those questions to make sure that you do have a better understanding.
And this is about studies and about caregiver engagement. And your loved one is going to be so much more successful with your involvement, with you advocating for them, with you understanding their disease process, their discharge from the hospital, their follow-up care. I can't overstate that your loved one will do so much better with your involvement.
And these are just final tips. I mean, just again, ask questions. Again, there's so many names that we can be called. Discharge planner will definitely get the point across. There's a lot of nuances, and there are going to be a lot of things that you're not going to understand, and you're trying to get that grasp and that better understanding to help your loved one at home or to that next level of care. Is really going to impact, the longevity of their life. But I want to leave time for questions, so I don't want to have to read all of those.
Okay. So, any questions?
At what point did the family, you gave them 25 nursing homes, some 50, and they're like, I don't want any of this, I want this one that my mom was having. How long do they have realistically to consider that, or is it already they said that that's not an option?
So We try really hard to understand where that family member is coming from, where that patient is coming from. So we don't say, hey, you have 1 hour and that's it. If you don't choose within 1 hour, we're sending you to wherever. But we do set expectations of, hey, your discharge is upcoming. I want to be sure that we have a bed for you when the doctor says you're stable for discharge. If we don't make this decision today, then you may end up discharging home, and that is not the safest option for you. So, I mean, there's not like a time limit where we're like, you have an hour. We try really hard to work with the patient and the family to make sure that that's set up well before their discharge date.
That's why we try to be as proactive as we can. I mean, if we know from day one that that's going to be the option, and the anticipated length of stay for a loved one is 5 days, that will give three, depending on the insurance, several days for us to work with them, to work with you, to work on that plan.
So if a patient gets discharged and the order is to go to skilled nursing, if the patient refuses and say, hey, I just want to stay home, they're able to pay for care, is there a reason why home health care are not able to perform the same way as a rehab?
So home health care, their services are way more limited than a skilled nursing facility. Home health, you may get therapy maximum 2 times a week. At skilled nursing, you're going to get around the clock care for your ADL. So they're going to be changing you if you need to be changed, taking you to the restroom. Your meals are provided. But if you go home with home health, you're going to have therapy maybe 2 times a week. And then your loved one has to make sure you get to the bathroom. Your loved one has to make sure that you get meals, make sure, like all of the things. So
Similar to build on that question, if they don't want to go to the rehab and you still want to go home, like physical therapy, would that be covered by Medicare?
yes.
And
So home health is covered by Medicare and most managed Medicare plans at 100%. There's not anything out of pocket for home health. That is a skilled service. So it's a limited service. They're out there 45 minutes to an hour at a time, and they might come out twice a week. So you might have a nurse that comes out and a physical therapist that comes out, or you might just have a physical therapist that comes out. So it is a limited service. But it's just for skilled needs. So when patients need help with meal preparation, with getting to the bathroom, with ADL assistance, home health care is not going to be sufficient.
And I think the other big thing with home health is you have to be homebound. Like there cannot be another way for you to get that need. If you're out driving to somebody's birthday party, or if you're out driving around town, then home health for Medicare is not appropriate. So we might set it up, and you might say, "Oh yeah, I can't go anywhere," and then home health might come out, and you tell them, or a loved one says, "Oh yeah, I'm going here, I'm going there, I'm going on vacation next week," and they're going to say, "Okay, we're done. You don't meet this qualification," and so then they might look at doing like an outpatient setting.
Somebody's made to skilled care, they're not going to be going anyway, they're going to be stuck with a skilled care institution and will not have the ability to come know as they please. So I think that's a choice. That is, if you're obviously making it sound like somebody has to go here, they can't go home, they just need independent. So Medicare does pay for some people to come in, and the new Medicare will pay for somebody to come and do your dishes. That type of thing, and on a limited basis, not on a daily, 24-hour basis. Okay.
So I don't know of any Medicare that will pay for home care for the cleaning. I mean, there might be an occasional, Advantage plan that has a perk to get somebody to enroll in it. But Medicare, traditional Medicare, CMS does not offer anything that's not for a non-skilled need. Now, just because home health isn't an option for therapy doesn't mean that outpatient therapy is not an option. Medicare will pay for those outpatient services, that might be more appropriate for someone who is able to get out and about.
Well, and to also clarify, when a patient goes to a skilled nursing facility, they can leave. It's not they don't lock the door and you can't leave. So Medicare allows patients to leave up to 4 hours for outpatient appointments, visits with families. So when you're in rehab at a skilled nursing facility, you are able to leave. You just have to come back. You have to come back within that time frame.
But also, Mary, they can leave before the 20 days.
Oh,
So a skilled nursing facility is kind of an at-will kind of like, it is not, I couldn't say if my parent were alert and oriented and said, I'm not going to a skilled nursing facility. And I say, yes, you are. I can't take care of you at home. Well, unfortunately, if my mom has capacity, she's alert and oriented and she has capacity, she has the right to make bad decisions. And that's really hard for family members. Because we want the best for our loved one and we know that they might need that level of care. But if my mom's alert and oriented and she refuses to go to a skilled nursing facility, I cannot make her go. Just like today, nobody could make me go. It's the same concept that we can't force family members to go if they're alert oriented.
We come at it from a different angle, so you're suggesting the patient may need skilled care. What if the patient doesn't need 24 hours skilled care? But they need something, so they need physical therapy a couple times a week. Broken hip, but you can live at home. Do you help with that? Is that?
We would set up home health care that is covered by Medicare because it's a skilled service. So we would be able to set up physical therapy to come out and visit them. But if, I guess to clarify what Mark was saying earlier, is that if that patient is not homebound, so let's say that patient is going to bingo and going to all these events outside of the home, went on vacation, then home health care cannot bill Medicare because that's fraud. One of the conditions for them to be able to bill Medicare is that a patient is considered homebound. So if they're homebound, they have a skilled service, then we can set up home health care. It requires a doctor's order, and we would set up home health care for physical therapy, and they would do skilled service. So they don't come out and do dishes. They don't come out and do personal care. They won't sit with somebody. Medicare doesn't cover custodial care, but they'll cover the skilled service, like medication management. Yes.
How do you guys obtain that, like, close to discharge care often for showing patients?
So most hospitals will use a platform for their post-acute services. And so we typically will provide a choice list. There are agencies in the community that we have partnered with. And so normally, those would be at the top and it would specifically say, quality partner, or someone that we would use regularly. Also, if a system has any financial obligations, or if they own an acute rehab, they're required to disclose that as well. I mean, we can't just say, oh, you need acute rehab, you're going to go to Joe Glancy because we own it and we want money. And so, that's typically how ours goes. And then there's also going to be the link to Medicare.gov. We always encourage, family members and patients to do their due diligence. Unfortunately, or fortunately, as a healthcare system, we are not allowed to provide other recommendations. I can't say, my mom, went here, or, oh, this company, they brought me a fruit basket, and they're a great company. I recommend to go there. I mean, we cannot make any recommendations. It is entirely up to the patient and their loved one, which can be kind of difficult because it's, that time, and it's hard for us, trust me. There's so many times where I'm just like, oh my gosh, please not, please. And it's hard, but, we have to be very mindful and very careful to, not step across that bridge because we can get in a lot of trouble.
Are there places that families can go to kind of do their due diligence? Like you give them a big list, and
Yeah.
what would you recommend that they do that wouldn't get you all in trouble, but they can?
Yeah, so I mean, I would recommend Medicare.gov. They have a rating system of, like for a facility, they have a rating system 1 through 5.
Where is that? I know.
Just in Google. I mean, I have the link on the PowerPoint, but you just have to type medicare.com/ this, yeah, compare care. And I think there's home health as well. It'll give a rating scale and it'll see if they have any infractions, if there's been, their staffing ratio. There's question on how much it's updated. But I honestly, with that, I would go to the facility. I would speak to the rep. I would check Google. Be mindful of Google. Obviously, people are going to leave reviews when they're not happy. But that's still an option. And then friends. Who did you use? If you go to church, if you're on social media, hey, what was a great company? Who would you recommend? I know in Cherokee, there's Cherokee Connect, and there's always something like, hey, my mom needs hospice, like who's a good company? And there's a lot of support and a lot of firsthand knowledge of people that did have a good experience. And if for some reason it's not an experience that works out, then you can always switch. You're not confined to a skilled nursing facility. If you're not happy, you can peace out and say, I'm gonna go home, or you could say, hey, I'm gonna get transferred to this other facility, and they should help you make that happen.
So, what's usually somebody, because I mean, let's be honest, skilled nursing facilities do not have the best reputation, generally speaking, and you have to have eyes on them. I mean, you don't walk in there every day as a caregiver or a family member, they slide. I mean, when my mom was in, when I was there, I was the evil witch. I mean, I really was. They used to say I pulled my Texas Roadneck right out of the box. But yeah, I mean, that's how quickly do they have to respond to you if they're not taking care of it, if they're not coming in and doing, you're seeing that. What repercussions do consumers have? I mean, is there an organization you can?
So I think the first thing that, once your loved one gets to a skilled nursing facility, and if there are hiccups, there's issues with care, the first thing that I would recommend is to speak with their director of nursing as fast as you can and say, hey, I don't believe this is the norm here, but this is what happened. How can we rectify the situation? Because I want my mom to get good care, and I believe she can get that here. So that would be the first thing that I would do. Well, I'm wanting something from them, right? And I want them to take good care of my mom. So I'm going to work with that facility. And at the end of the day, I'm going to, when I speak with families about choosing skilled nursing facilities, do they want to choose a 4-star facility in South Atlanta? Or do they want to choose a 2.5-star facility in Elgin, where they live? My recommendation in that scenario is your loved one's going to get better care if you're there every day. So you can try and get a 5-star facility, but if you're there once a week or just once every 2 weeks, then your loved one's going to get better care when you show up every day. So, but yes, the recourse is first go to the director of nursing or the administrator there. And then if that is not rectified, then there is a long-term care ombudsman that would be able to take grievances.
And are they usually in the facilities?
They're not in the facility. You have to call them and you can file a form of grievance.
A lot of this is like, a lot of stress and pressure on the caregivers. Like, what does Northside in most hospitals provide as far as like support for the overwhelmed working caregiver as kids in the job and then just expected to, do the list of things?
So, there are virtual support groups for caregivers. And if I'm gonna be honest, there's probably a lack of resources in that area. I mean, we're all I'm coming to an age where I'm gonna be caring for my mom. And I feel like in our community, that's something that we absolutely should look more into.
So that's a great question that you're getting into.
That's a great question, and it's really hard because especially when it comes to finances, it is immensely overwhelming. That we are limited in some ways on that, but what we do is we try to have our chaplains who are not just chaplains, they have a lot of connections in the community. And we try to get them to see, okay, what are the needs, talk to the family, sit in a quiet place and find out what's going on. And then based off that, between our partnerships with everyone from Goshen, and I say Goshen because people don't realize in the last 2 years, they brought an immense amount of behavioral health support to our local community. But we find the difference, must ministries, all those, if it's something that they need to help supplement what we can't, let's find one of our partners that can. But that the whole emotional of like, how do I manage it? That's a hard one. And we refer back to our chaplains because we then go, okay, do you go to a church? We try to find someone who's already in their life to help get them integrated to that. But that's an area that it comes down to, let's find out what's overwhelming you. Is it something that we can then connect you with someone we know and they are more than happy to come in and talk to you? Or is it you just need someone to be there and help you navigate emotionally dealing? Because I've been in those shoes with my mom who's 84. The first thing is getting past her emotional being overwhelmed and then breaking it apart to bite-sized pieces. So it's not something that the hospital can do, because what we have found is that when you get into the hospital and we tell family members, take a break, take your time now and stay rested, because your hardest part is going to be when discharge comes. And especially if you're in the ICU, you have people with your family member 24/7. There's usually a very low ratio, so they're all over it. Take advantage. Don't necessarily sleep on the couch every night. You would do it because you need it, and we understand that. But make sure you're giving yourself a break, because once you go to that discharge, navigating that is really hard, especially if your parents have not planned or prepared for it. My mom fought against it. I was blessed that I had, because she's in Virginia, they had a skilled nursing facility she went to for rehab. They would send me videos because I'm like, there's no way she's ready. There's no way. They take a video, they send it to me and go, oh, you're right, she's ready. Okay. But it is finding those partnerships, and it's not easy, and I agree, but it's figuring out what do I need to help me break this to pieces. And then we can't help you, but we can find people who can.
And this is something that we are really looking at, because the last thing that we want for discharge planning is an overwhelmed caregiver who stops answering the phone and their loved one is incapacitated and lacks capacity, and the loved one is just so overwhelmed that I'm done. Don't talk to me anymore, don't call me, I'm not involved in their care. And here we are now with someone who can't make decisions and, has nowhere to go. And then Mark gets a phone call and says, hey, like, we're having some issues, and we might need to find a guardian. And that's not what we want to do. And, most of the time, that's not what the caregiver wants to do. And so we do work to try to find out, where is that fatigue coming from? Where is that stress? How can we lean on our community partners? And, how can we provide, resources and direction? Maybe it's respite care. Maybe it is, looking into home care and working with one of our partners to find out, this one's going to be the most affordable. So there are options, and it's very overwhelming. It's something that, as population continues to age, we're going to see a lot more of, and hopefully we continue to eventually get on the right side of it.
If I may add, I work at the rehab team in Northside Cherokee. I'm not here on behalf of Northside tonight, but I do work on the ground. And what I will say is, if you are a caregiver that's feeling overwhelmed, as much as it may feel like you might feel like a burden to your care team, being the sweet people, bring up the problems that you're having, because while Northside overarching as an organization did not have all the resources, everybody that's on your team knows somebody, who knows somebody, who knows somebody. So for me, for instance, I'm here today, I might know somebody who might benefit from being a robot agent. And they say, oh, I love this experience, the next line is easy. While Northside or Arching, they may not have that resource, that member of your care team, you want to say, well, you know, I talked to such and such, and they use this organization, or here's a resource for, or you can afford the piece of medical equipment. And I found that a lot of our sort of boots on the ground staff are very active in the community and trying to find these resources, because it does not feel good as a member of that team to not have the answer when somebody says, hey, I'm thinking of a wrong, or hey, I don't have an answer. So we are also all constantly searching and trying to find, and the reason why we're at events like these tonight, to build those connections. And so I tell all the time I have family members to apologize and say, I'm so sorry, I'm complaining, or I'm talking about this, or whatever. We would rather hear it so that we can either connect you with a third party, or connect you with someone else that we know in the community to get you connected with those resources, because it's the good thing about the current day and age is there's almost a resource for everything. The poor thing is because there are so many resources, there's no one person who knows everywhere to go for everything. But the more you talk about it, the higher the odds are that somebody knows somebody who knows somebody where you need to go.
Thank you. Any other questions?
Sorry, I know just, I'm very lucky my parents are not at this stage yet, or having to make these plans, but as they are getting to that stage, are there questions and information that I need to be asking while they are still totally cognitively intact, just so I can say, hey, if things go poorly, if you have a stroke, if something happens where you are not able, you know, to be in control of your faculties, here's the information I need to be able to take to your care coordination team when you're trying to figure out where to go.
Advanced directive.
But also be involved with community like this, because I think always there's people like planning is key before you get to that stage. So if you plan and you know every single thing and you know the resources, it's always easier to, you know, it's still gonna be panic situation, but it's always easier to open your Rolodex and start, you know, executing those plans, right?
I never really appreciated the value of a power of attorney more than until I got in my role, and I realized that it is not as common as I would have hoped. And you know, some of the placements, you know, if a loved one can't be taken care of at home and they have to go to a facility and have to live there for long-term care, you know, there's certain things that are required that for Medicaid to cover that expense at a facility or skilled nursing facility that you might not be able to get without a financial power of attorney. And if you can't get that, then you know someone's going to have to get creative, or it might mean that someone has to go and work with an elder attorney to help get that arranged. So that would be my biggest thing: power of attorney, advance directive, know what they want, know what they don't want, and get it in writing, get it notarized, get it signed.
And Georgia has free advanced directives that you can print online. And it also takes the burden off of your family member. Like after I got my role, I have an advanced directive. I don't want a feeding tube. I don't want to be put on life support. And now my husband, my children, they don't have to carry the guilt of not doing that because I've already said, that's not what I want. So having that in writing and everybody know where it's at is going to help if that time comes, that they don't have to feel guilty in saying, well, I don't think mom would want that. Now they know mom does not want that.
And then I'm going to come along and say she does.
Any other questions?
Is there a period of time in which family members have discharge, can contact your side again for referrals and resources of things that may or not?
Absolutely, yes. So we at Northside, we are heavily involved in the discharge planning of our patients. When we talk about hospital readmission, nobody wants your loved one to have to circle back, kind of like that slide, circle right back in. So not only is it not helpful to the patient and the family to go on this constant merry-go-round, but it's not good on the hospital, and Medicare says you're not doing something right if your patients are circling back. So we do have, when our patients discharge, if there's a need within that 30-day after their discharge, then you would contact the care coordination department, typically leave a voicemail and say, hey, my mom, Susie Smith, date of birth, 1/1, whatever, she discharged from the hospital yesterday, and I've realized that I need help, and I think we are now wanting a skilled nursing facility. Then one of the care coordination supervisors would call you back and we would start working on that. And that might look like mom's gonna be home with you for another few days, because now we're gonna get home health out there to do a physical therapy evaluation. Because that's what's gonna be needed for Humana Medicare or Aetna Medicare or any of the managed Medicare plans. They want updated recent notes from therapy.
So 30 days pretty much industry standard for after.
So that's the CMS standard for readmissions, but I mean, I'm assuming most hospitals have this too, but I know at Northside, we have a team of nurses that will follow up with patients after they've discharged. Now, there are certain criteria in which they will follow up with certain patients. But typically if they discharge home, then they're gonna call and it's different intervals. I think it's, within 72 hours. And if things aren't working then, you would be able to vocalize that, and then we would get an email saying, escalation, please reach out to this individual.
Any other questions? We've kept you longer than we should.
Thank you. Well, thank you to Mary and